Hey, good morning, everyone, and welcome to the UroPatient podcast. I'm your host, Vic Sinise, bringing you the best in urology patient education. We bring this to you every Saturday at 10:30 a.m. Central Time over YouTube and Facebook Live. Best place to go to see our show. And if you're new to the show, be sure to check out our website at UroPatient.com. That's the best place to find out more information about our show, how to watch past episodes, and all sorts of good stuff. And don't forget to go to our downloads area because every episode has its very own download that you can download information about that episode, patient education to take home. This week, we're going to be continuing our journey on BPH treatments with Optilume for BPH. It's part of that, what we call MIST procedures, minimally invasive surgical treatments for prostate. We've done Resume and UroLift, and now we're going to go right over to Optilume. And I'm glad to have Dr. Dean Alderman, who's going to be talking to us about that. So let's bring Dean in right now.
The prostate. And so now enters Optilume BPH. So this is taking that technology that we had from the stricture device and applying it to the prostate. So it comes in a standard box. And what it's going in that box is going to be a couple components. One is something called the pre-dilation balloon. And number two is going to be the drug-coated balloon. And then, of course, there's going to be a pressure gauge to actually increase the pressure by connecting it. So this will become a little bit more clear in a moment. This is what the Optilume balloon looks like. So it's essentially a double balloon. It looks like in the old days, there was actually some double balloon type of Foley catheters. So it's a double balloon, and it's inserted into the bladder, and then it's pulled back. The furthest balloon is actually going to sit in the bladder, and the second, more distal balloon is going to sit in the prostate. And it's sort of shaped like a figure eight or two bubbles. And where those two balloons meet is where it's going to lock into the bladder neck. And so there were actually balloons designed for BPH called the Dow balloon in the late 1990s. And there was a lot of excitement and fanfare around these balloons, but the problem was that, number one, there was a lot of migration. They would slip forward into the bladder or slip back because they didn't lock into place. And two, they just didn't have durability because they kind of stretched the prostate, but they didn't fundamentally change it. And of course, there was no drug coating to prevent the prostate from closing down again. So that you can see from this double balloon, you're going to ensure that if it's positioned correctly, which it will be, you're going to have that distal balloon holding it in place in the bladder. The distal balloon will be in the prostate, the proximal balloon will be in the bladder, and it'll expand. And what you're actually getting is an opening of the prostate at the 12 o'clock position. So the other thing is that it's customizable. In other words, you need to know the distance between the bladder neck and the external sphincter, because these balloons, the balloons for dilation and the balloon that has the drug coating, come in different lengths. And so you can see that what we do is we position the system so that the first balloon is in the bladder, the second balloon is in the prostate, and it's that second balloon that's being expanded open, causing the prostate to essentially tear and open up at the 12 o'clock position. The prostate's almost like a peach, and it splits open at the top. And the end effect is this anterior commissurotomy. This is the key to what it's doing. The prostate is not going to split anywhere else. The prostate will naturally cleave where the left lateral lobe and the right lateral lobe meet. And you're going to create this open and essentially raw surface up at the 12 o'clock position using the pre-dilatation balloon, such that when you put in the second balloon, the drug will then be released right into that raw surface. It'll expand it, dilate it, get absorbed in, and prevent it from closing down again. So you're effectively opening up the bladder outlet. And here's the 4-year results, essentially showing that at 4 years, you're going to have close to 70% of men responding to the treatment, having a 30% improvement in their symptoms, having at least a 3-point improvement in their IPSS. So that is a very good number to hang your hat on when it comes to a minimally invasive treatment. The other big story when it comes to the Optilume BPH is the amount of improvement we see with flow rates. It is very significant. We're seeing from about an 11-point peak flow to a 18 mils per second sustained out all the way through 4 years. And the post-void residuals, of course, go down commensurately. And we can see here again the schematic from the study essentially showing the one balloon sitting in the bladder and the second larger balloon going into the prostate, causing the dilatation and getting that drug coating all the way into the tissue. Another important aspect of these minimally invasive treatments, of course, is sexual function. And as has been seen in some of the other myths, with the Optilume BPH, we see no change in erectile or ejaculatory function.
What anesthesia do you need to use for this?
So in the clinical trial, it was either general anesthetic or mostly conscious sedation, right? So all of the ones that I've performed have just been using propofol. You are still using a rigid scope. No one has really sort of figured out how to do this yet through a flexible scope. And I think it's just a matter of time before we essentially find a way to introduce the Optilume BPH through a flexible system. And then you can have your flexible scope positioned at the external sphincter, and then you may not need any sedation whatsoever.
How does this procedure compare with UroLift, Resume, and green light laser? I know you touched a little bit about those all being minimally invasive. What are your thoughts? And I guess maybe throw iTind in there also.
Well, I think the Optilume BPH would still be considered a minimally invasive therapy, a MIST or a MIT. It can be done in an office where you're able to give some sedation. The degree of improvement in IPSS, pretty similar. I think it's the flow rate that really separates it a bit. As I said, you're going to see a greater flow rate. And the other thing too, perhaps, will be the time it takes to heal, because you're not using any steam. You're really not doing any puncturing. Perhaps, and this is a little bit more anecdotal, patients start to feel a little bit of a recovery a bit quicker, because again, it's just more of that dilatation, the drug is in, and then you're done.
I'm guessing they probably still have a point where they're kind of miserable for a while before things get better. The burning,
so, we leave a catheter for 24 to 48 hours, which I think is very reasonable. It's all outpatient. Nobody's admitted for CBI. And I think an element of frequency and dysuria for a week or two afterwards would be entirely expected and reasonable.
How long does the procedure take?
Yeah, so I'll tell you exactly. The pre-dilatation is 2 minutes. The dilatation with the drug coating, if I remember correctly, is 7 minutes. And when you do the urethral stricture, it's 10 minutes with just one dilation. So you take 2 minutes, 7 minutes, okay, let's call it 10 minutes. And then essentially what you're doing is you're putting your scope in, you're passing it in, you're putting your scope out, you're putting it alongside, you're positioning it, and you do that 2 times. So realistically, I think somewhere between 15 to 25 minutes is the time it takes.
Any BPH patients that wouldn't be a good candidate for this procedure?
So because it's based upon prostatic urethral length, the distance from the bladder neck to the external sphincter, and you have balloons in different sizes, you have to select, do you want a 3 centimeter, 3.5, 4.5 centimeter. You can't have a prostate that's too short or too long, right? Because you don't want the balloon to go out into the external sphincter. And of course, you don't want the prostate to be too big for the treatment to be done.
Hey, that was really great. I'm glad I was able to have the interview with Dr. Dean Elterman. I guess he was one of the early researchers on Optilume. I have to admit that I don't have any patients that I personally can attest to talking to about this procedure that they've had it done. So that's why I had him come in, did an interview with him earlier about the questions that I think are really important for patients to know. Just kind of a review though. Anesthesia, as we mentioned now, even though this is minimally invasive, this one has pretty much been done in the OR now. So it's an outpatient and under general anesthesia. So when we get to our questions, how is it done? Outpatient. As he alluded to, that this probably will be moving in office. Now, some offices have the ability to give Propanol, the medication he had mentioned, in office. Ours does. So this is something that could be considered an in-office procedure too. How much will it hurt? Well, because of the amount of anesthesia used, it's probably something that's zero hurt. It's not, you're not going to feel anything. And as he said, how long does it take? About 25 minutes. So it does take a little bit longer than some of these other 2 that we mentioned, but still relatively short. how long is the recovery? And as he said, about 2 to 3 weeks to get back to normal. Now, the one thing he did mention is the symptoms, the burning and urgency and all that other stuff that we typically see with the other two procedures that we just talked about, is much shorter with this one. So I think it has that little bit of an advantage. And then how well does it work? Well, again, good data on it. It does work. Prostate ballooning has been going on for quite a while, and the only problem is it didn't really work very well until they got this medication covered balloon that helps to really make the difference. And as he mentioned, having that double balloon so that it stays positioned in the right place has made a big difference. So I even learned something new about the show. A viewer just recently used this thanks button. It's on every episode, and you can use that to support the show. You can pick any increment of support that you would like to give. You can even go in and change that emoji so that you can customize your thank you. And when you're finished, you hit the buy and send button and go ahead and send in your contribution. We appreciate any help we get. So next week, we're going to continue on our journey, and we're going to talk about another treatment for BPH in that MIST realm called ITIN. So that'll be interesting. We also have another guest speaker coming in for that one too. So please be sure to join us on UroPatient.